Right. We better get things underway because there's a bit of content to get through. We've only got an hour, and I want to be able to get everything to you guys. My name's Joel, and I'm a doctor on the anaesthetic training program working in Melbourne, Australia. And we're going to talk about pain management, essentially for a ward-based sort of approach to pain management, which is appropriate for medical students and junior doctors, just to give you a bit of a one-on-one on how to manage pain once you do get to that point of doing it in your junior doctor years. This will be recorded and available online. So thank you everyone for being involved. If you would like to engage with me and answer some questions, then just check your camera on and I'll throw some questions at you. Otherwise, I'll choose some names. If you don't want to answer a question, that's completely fine. You just let me know. We'll move on to the next person. All right. This is me, yes. I'm a 6-year doctor's second-year anaesthetic trainee, currently doing my intensive care term at the Royal Melbourne Hospital, and I've worked in several acute pain registrar roles throughout my training. I know you've all got here because you've engaged with the Heroes content in some way, but do join on all the socials, including Twitter, Instagram, Facebook. So just some real basic ground rules. We're here today because we all want to learn. So I will ask lots of questions. If you don't answer them, that's okay. But the more involved you get, often I find the more you get out of it. We all know you're all capable and intelligent people. So whether you get things wrong or right, it doesn't really matter. We're all just here to learn, and no one's judging. Unless you want to judge Bjorn's form. All right, let's get straight into it. So what is pain? I'm going to ask you, can you give me a basic definition, what you understand of what is pain? Maybe Stevie.
It's a sensation that typically arises from noxious stimuli from the nociceptors. So it can be heat, like stinging, burning. So anything that's perceived as sort of a physical negative sensation, I guess.
That is a really good, I think, summary of the way that we sort of perceive pain in general. This is the International Society of Pain's definition. So an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So you mentioned nociception there. Nociception is not necessary for the experience of pain, and it is a deeply subjective phenomenon, as I've said here. So nociception doesn't equal pain, but very often the two coincide. Stevie, really quickly, can you think of a time when you might have nociception but no pain based on this definition?
Maybe I don't know if heat comes through nociceptors.
So it does. So when someone's under a general anaesthetic, they are not having a a conscious experience of pain. They would not meet this definition by the IASP, but there's still nociception occurring by their nociceptors. So we do this every day in anaesthetics, give people nociception without pain. And there's a heap of things that go into influence your pain experience, including all the things that I've listed here. It's a truly biopsychosocial phenomenon. And there's plenty of other things I haven't listed here that affect it as well. Okay. I'm going to give you a couple of really quick examples and we'll talk through them. So if a patient, based on the definition we just looked at, if a patient flinched and yelled that something hurt before a cannula that was about to touch their skin, even touches them, they tell you that hurts. Emma, do you think this is pain? What about Nick? Do you reckon this little example I've given here constitutes someone experiencing pain?
Looks like they're experiencing it.
Yeah, I agree with you. So this is it's a sensory and emotional experience associated with actual or potential tissue damage. So this is someone feeling that sensation of pain in response to potential tissue damage. And it, as it's a subjective experience that needs to be respected. However, our typical ways of treating pain might not work for this person, given it's not actually nociception. I'll go through the rest of these really quickly. So I think we can all agree that if they report sharp or localized pain as you insert cannula, then that is pain. Several days later, the cannula site becomes red, tender, and warm to touch. The patient reports the site throbs with dull pain, and they get an infection which prolongs their hospital stay. All of this sounds to me like it would constitute pain, with the complicating factor of an infection now. And then finally, several months later, the infection's healed. There's no more cut there. Chris, do you reckon this several months later example with patient continuing to report pain over the site with tingling and numbness, does that sound like pain to you?
Yes, it does.
Yeah. And what kind of pain do you reckon, if you got any buzzwords that might describe this kind of pain in the most basic sense?
Like paresthesia? Neuropathic.
Neuropathic's a great word. And I'd also call this chronic pain. So the definition of chronic pain is pain lasting more than 3 months after the initial insult, once the initial insult has already been removed. So this would fit that criteria. So these are all types of pain. Now, as junior doctors, you'll often be called to see people in pain. And I know you've all gone through this in uni before, so we'll just go over it briefly now. But how do we assess the patient in pain? I might ask Al if you can give me do you have a structure that you would follow to take history from a patient in pain? What about Beck? Do you have a structure?
I guess I'd go through site quality, severity, that kind of thing.
Yep.
Time course, context, all that kind of stuff.
Love it. Excellent. So basically different universities learn different acronyms and ways to remember things. I've heard of Socrates before being used to assess symptoms, and you can also use what we're going to use now, which is sort of a who, what, when, where, why type assessment. The first thing that I would always say to any patient that I was asked to review for their pain is I would always use an open-ended question to start, because the initial response to this question is often the most helpful in telling you how significant this pain is, what it means to the person, and give you little clues about how you're going to deal with it. So you can follow just a very simple who is this patient, and what are the factors that influence them in their lives. What? So you characterize the pain. What does it feel like? What's its severity? What are the associated symptoms, aggravating and relieving factors? When does this pain occur? And not only when does it occur, but when does it go away? Does it come and go? And if so, is there a periodicity to that? Is it a few hours at a time, a few minutes at a time? Things like that. Where, location, radiation, pretty self-explanatory. And then how. So this is often the most important question for patients. It's not just that they have pain, but it's that it's affecting their life. They can't sleep, they can't work, they can't engage in their relationships normally, they can't lift their kid up because their arm's too sore. You never know. So that's a potential structure you can use, but it sounds like most of you probably have a good structure of your own that you've learned along the way, regardless. So we're going to go through a few quick vignettes, and I might ask one of you to just tell me what you think this sounds like based on these questions. So they're all going to have the same stem. It's a 63-year-old female presenting with a headache, and this is what you get on history. So the onset's been gradual over several days. The severity is moderate to severe. The character is dull and throbbing. She feels hot and cold. She's got subjective fevers, sensitivity to light, and finds that a dark room and simple oral analgesia are helping her with her pain. It's only been going on for 1 to 2 days, but it is constantly worsening. Who's H? H, do you have any idea what you think this might be? Or Lois?
Would it be like meningitis?
Yes, it sounds like meningitis to me. Totally agree. Let's do one more. So why don't you see if you can get all three of them, Lois? So this one's acute onset over minutes, very severe, dull and localized to the back of her head. She's lightheaded. She's got nausea and vomiting. She hasn't noticed anything that brought it on, and nothing's making it better. And it's getting rapidly worse. What do you think this sounds like?
A subdural hemorrhage?
Yeah, I think it probably sounds like some kind of bleed, probably more in keeping with the subarachnoid. But I definitely think you're going in the right direction there. And then finally, I'll give you one more. So same lady, same headache, well, different headache. Gradual onset over months, mild to moderate in severity, dull and throbbing with associated weight loss, night sweats, lethargy, vertigo. It gets worse when she lies flat or leans forward. And initially she did get some relief from simple oral analgesia, but it's less effective now. It's been going on for several months, as we said. Generally getting more severe, though it waxes and wanes. What do you think this sounds like?
I'm not entirely sure. Would it be a tumor of some sort?
Yeah, to me, it sounds like some kind of slow-growing tumor, which is probably having some kind of mass effect. Yeah, excellent. So you've had the same STEM, you've asked the same questions, but you've got three entirely different histories, and you've come up with three entirely different diagnoses, all of which have starkly different treatment strategies. Lahiru wanted me to let you guys know that he was actually he observed some surgical examinations for advanced training once, and one of the candidates didn't ask about time course and therefore couldn't differentiate between two very different pathologies. So for your entire careers, you'll be coming back to these questions about that you've learnt in medical school and the structure that you've learnt in medical school. And make sure you always stick to it, because even when you get to a specialist level, it really just comes back to basics, and you'll be able to really differentiate what's going on with a good history. So great job, Lois. Okay, so we want to assess the patient in pain, and we're doing it for a reason, and that's the why. If we, as I've just said, if we all ask all these questions, we can make an educated guess as to the cause of the pain. And knowing why pain is occurring is essential to treating it appropriately. It will enable you to tailor your management plan to the patient in front of you, address acute, potentially life-threatening pathology, avoid prescribing medications which may cause more harm than good. And also a good history with empathy builds trust and rapport with your patients. I might just take a quick moment. Ruth, is there any questions in the chat that I need to know about?
No questions in the chat at the moment.
Yeah, cool. All right. Okay. So we're going to assess some severity. Sean, very quickly, any methods you might use in your practice to assess the severity of someone's pain?
You could use the visual analog scale, like 1 to 10. Yeah.
Yep.
Or the faces for children.
Beauty. Completely agree. So you're sort of referring to a pain score of 1 to 10. Yep. They're discrete. They give exact numbers. They're subjective, so they're relevant relative to each patient. But they're really, really helpful for assessing pain over time within the same patient. They may change over time with activity, medication, and mood. However, it's important to note that they're highly variable between individuals, and 6 out of 10 is not the same for everyone. But if you're seeing the same patient day after day on the pain round and their pain scores are getting better, then you can be pretty sure that they're improving over time, which is good. Other options. So you already mentioned these. So the Wong-Baker faces, which you might run across in your children's rotations. So these are a well-validated way to assess pain in children. I apologise, I can't remember the age range that you're meant to use them in, but there's a lower limb age cutoff, which isn't coming to me right now. And then you can just be really, really basic. You can say is it mild, moderate, severe, small, medium, large. Okay. Once you've assessed severity, I'll stick with you for a moment, Sean. You've assessed the severity of their pain. Now, what else, and we've already done the full pain history, is there anything else that you care about in regards to their pain? Or what what things I'm going to lead you directly to it right now. I'm thinking about, so let's say you've got an 80-year-old man at home. He's usually walks around with a 4-wheel walker, and now he's got a pain in his hips. Doesn't really prevent him moving around too much, versus an elite athlete who's got similar pain in their hip, but it's preventing them from engaging in their sport and their livelihood.
Okay, so like how it's affecting their activities of daily living, that kind of thing is.
Yeah, exactly. So how's it affecting this person's function? And then we can further categorize functions into exactly what you said. So activities of daily living, things that you need to do every day. So essential things. And this is like sleeping, eating, walking around and moving, and particularly many post-operative patients being able to deep breathe and cough. Not being able to do this is almost a surefire way to get a hospital-acquired pneumonia post-operatively. So that's why it's so important that we manage patients' pain well in this period. Then there's other functional things we can assess. So site of injury function, of course, is important. And then anything specifically important to your patient. So in that example, being able to run around and be agile and quick is clearly important, more important for one of those two people than the other. And so it's important to draw those things out in your history so you can assess the level of severity of the pain for this patient in the way that it's affecting their life. And then there's something called a functional activity score, which we use quite regularly on the pain round. And this essentially categorizes people into A, B, or C, no limitation, mild limitation, or severe limitation to their activities. It's a very, very crude score, but it can be helpful for documenting over time how someone's progressed in regards to their pain. So you might find someone day one post-op is C, and then if you get them to B on day 2 or 3, then you know that you're winning and going in the right direction. Okay, so your patient might not be able to tell you they're in pain. So there may be other ways that we can know that our patient is in pain, even if they can't tell us. It's often more helpful in children. Can you think of any clinical features of pain? Lucky next is Alex Kwan. Any ideas?
Vaccine, tachypnea, maybe like tachycardia as well, I guess.
Yeah.
Their vitals could be changed.
Yes. What was the first thing you said, sorry?
Tachypnea.
Oh, tachypnea. Yeah, absolutely. Yes, totally agree. So really objective signs. So vital signs, exactly right. So tachypnea, tachycardia, hypertension are all commonly associated with pain. Can you think of how any other vital signs might be deranged by pain?
O2 sats?
Yeah. How might your O2 sats be changed by pain?
Oh, they'll go down with pain.
Yeah, and why?
I'm not exactly sure, sorry.
That's right. Also, if someone's the example that we just discussed. So if someone can't cough or deep breathe because their pain is really severe, then they may be inefficiently ventilating. They may be hypoventilating, and then in that situation, you may find they become mildly hypoxemic. Yeah. In rare cases, more commonly in children, bradycardia and hypotension may be a feature in severe pain due to excessive vagal tone. It's always something to think about. Usually that's much more acute than the tachypnea, tachycardia, or hypotension you might see. Other clinical signs you might see: sweating, pallor, and that's it. Very quick slide. I don't expect any of you to remember this in any kind of detail, but pain is transmitted and interpreted via a complex series of neuronal pathways that starts in the peripheries, is transmitted to the dorsal horn of the spinal cord by the dorsal root ganglion, via the dorsal root ganglion, and then travels in the spinothalamic tract to the thalamus. So from spine to thalamus, spinothalamic tract. And from there, that signal is then distributed to the various areas of the brain that constitute your pain experience, including the limbic system and the somatosensory cortex, so you can localize pain. And you can see here on the right that all the agents that we use to treat pain act at varying levels of this pain pathway, but they'll all act somewhere on this pain pathway. All right. Very nebulous and open-ended question. Stuart, are you there?
Yeah, sure.
How do you approach pain management?
Yep, big question.
Big question.
Depends on their history.
Categories or structure.
Categories or structure. Medication approaches, sort of a more physio, allied health approach, and then also like a psych mental health approach to the pain, like making sure all three facets are given attention to.
Yeah, so it sounds like you've described pharmacological and then non-pharmacological ways to manage pain.
Yeah.
And those would all be relatively non-invasive, what you've just said. Can you think of any invasive ways to manage pain?
Depending on the problem, surgical approach.
Okay, that's really good, Stuart. So there's, I would categorize it, or one of the ways you can categorize it into it is invasive and non-invasive ways of managing pain. So surgery is an option, and regional techniques, particularly regional anaesthetic techniques, are options. Then there's non-invasive techniques. So there's non-pharmacological, of which there's a huge list of ways that we can manage pain. And then there's pharmacological options, which we'll get to in just a moment. So these can either be an oral form, a intravenous, or bypassing the oral route form, or they can be topical. Okay. Now, as far as which analgesic should you use, does maybe Freya, do you have an approach to deciding which would be your sort of first line pharmacological analgesic option, and then how to work from there if you're not getting success?
Yeah, sure. I personally still go back to the WHO ladder of pain management.
Yep.
First thing I do want to always check though is the patient's past medical history, because something like especially renal and hepatic issues can very much determine what sort of analgesia you use, particularly when you get to opioids and stuff. So first thing I'd do is look at the past medical history. Then I'd think about like first line paracetamol, then maybe adding an NSAID, and then going to your opioids third.
Lovely. Excellent.
And then, there's like also like your, what are they called? Like sort of amitriptyline, tapentadol, tramadol. Those sort of ones as well.
Yeah. So that's completely right. Yes. So the WHO analgesic ladder calls those adjuvants. And then you're completely right. So starting with paracetamol, moving on to non-steroidals if those are appropriate for your patient, plus minus adjuvants, and then moving through the opioids. So they describe them as weak and strong opioids, which pharmacologically isn't doesn't make the most sense, but we can still rationalize it in the different drugs that we're using clinically. And then, more adjuvants. So how much time have we got? Still now, maybe we do have time to go through these slides in a bit more detail. Maybe we'll come back to them if we do have time. So Ruth, do you mind just sharing that PDF of the pharmacology for these guys? So I've prepared for you guys, and just to make it very clear, this two analgesic ladder constitutes what we call multimodal analgesia. And all these analgesics have synergistic effects when used together and prevent the harmful effects of using too much of one or the other. So multimodal analgesia is the hallmark of any pharmacological approach to pain management. So what I've prepared for you guys is essentially some little cheat sheets for working through the analgesic ladder, talking about each step in that chain. So for each drug, we've got a drug, a class, a mechanism of action, and a usual dose. and then cautions and common adverse effects, which are probably the last three columns are probably the three most important for your clinical careers. As Freya mentioned already, hepatic and renal dysfunction can be significant players for some of these drugs. And for paracetamol, hepatic dysfunction is one of those things. So within the chat, we'll share a link, which is just to a PDF of all these in one, which you guys can reference anytime you like. Going through very briefly, we've got one for non-steroidals as well, with some dose suggestions and also the common cautions and adverse effects with non-steroidals, of which there are quite a few. And you'll often find that many patients that you encounter clinically have contraindications to non-steroidal use, which is very unfortunate because they're excellent analgesics. What is referred to as sort of weak opioids, sort of the tramadols and codeines. In the doses that they're used at, they have minimal or lower opioid effects than some of our other drugs. And in the case of tramadol, it also has effects on some other receptors, so serotonin and noradrenaline. It stimulates release and inhibits reuptake of serotonin, and noradrenaline reuptake is inhibited. For that reason, tramadol, I think one of the most clinically relevant things is that you need to be really cautious when you're using it with other serotonergic agents, particularly antidepressants such as SSRIs. Codeine's significance is that it has very unpredictable analgesic effects because it's a prodrug that's broken down by CYP2D6 enzymes, which have variable expression throughout different populations. So 9% of Caucasians will have very minimal clinical effect because they poorly metabolize the drug into the prodrug into the drug, whilst about a third of people from Southeast Asia will have a poor clinical effect. So a very unpredictable drug, and one I tend to avoid in my clinical practice if I can. As far as strong opioids goes, this is where your oxycodone, your morphine, your tapentadol come in. Tapentadol is different in that it also has some noradrenaline reuptake inhibition effects and some weak serotonin effects. So they're probably not significant enough that you need to worry about SSRIs to a significant degree when you're giving patients tapentadol. And they all have very similar adverse effects: GI, constipation, nausea and vomiting, sedation, respiratory depression, and then in the long term, addiction and tolerance. Why opioid stewardship is such a big part of.
Sorry, someone else muted you.
All good. All right, and then I've got morphine listed here. One of the most important things to remember about morphine is that it's broken down into some metabolites which are very active and have very potent opioid receptor effects, and these metabolites are then cleared renally. So morphine 6-glucuronide may accumulate in patients with significant renal impairment, and so we wouldn't use morphine in renal impairment. Long, do you have any idea what might be a good IV opioid of choice instead of morphine in patients with renal impairment?
Could it be fentanyl?
Yeah, fentanyl is a good choice. Yeah, it's commonly what we would use instead. There are many others that are also safe in renal impairment. Then adjuvants. So I certainly haven't listed all of them here, not by a long shot. And Freya mentioned amitriptyline, nortriptyline could also be included on this list, and I completely agree. So pregabalin and gabapentin, they work in very similar ways on this to inhibit pain signal transmission in the spinal cord. You have to be very careful when initiating doses for them. I've written 75 milligrams an octave for pregabalin here, but in a very old person, you might even start at 25 milligrams for 3 days and go up really slowly because it can cause quite significant sedation, particularly in the elderly or frail. And then I've just a couple others here: clonidine and ketamine. Ketamine you'll probably see quite frequently in your clinical careers, but usually not prescribed by yourself, usually prescribed by the acute pain service and often in post-operative patients. The most common side effect from that would be hallucinations, which may or may not be distressing for the patient. If they're not distressing, we tend to just keep it going. If they are distressing, then we may stop it, or we may just reduce the dose very slightly and see if those hallucinations go away. All right. I've already talked about the adverse effects as we went through those tables. These are the two most common by far. And they both relate to the mu-opioid receptors' effects on the gut and slowing gut motility. And I've also included some very simple ways to manage these issues with either aperients or antiemetics. There's many other antiemetics that you could use, and this is by no means an exhaustive list. Now, there are some uncommon adverse effects of opioids. Do you reckon you might know any uncommon side effects of opioids, but serious side effects?
I'm going to have a guess, but anaphylaxis.
Yes, so you can certainly get anaphylaxis to essentially any medication. I completely agree. That is definitely a uncommon and severe adverse effect of opioids. What about something that's more sort of unique or specific to opioids?
Angioedema. Oh, wait, it's kind of in the same basket, isn't it?
Yeah, so you can get a little bit of histamine release, particularly with things like morphine can cause some itch, but usually not too much angioedema. I'll put you out of misery. The thing I'm getting towards is things like sedation and respiratory depression. And these are the things that we're really concerned about in patients who get really high dose opioids. And it's often the thing you might see in someone who's used an opioid in the community, such as heroin or any other recreational opioids. You may see them present quite sedated and quite hypopneic or even apneic. So let's go to Sean Lee. How might you prevent these issues that I've just described, the sedation, respiratory depression?
Prevent them in a patient that you're getting to, or reverse the effect?
A patient that you're treating but does not have these symptoms yet.
Okay. I'm not exactly sure, but maybe like titrate up the effect or start low.
Yep. And how might you assess whether the patient is beginning to exhibit these effects?
Just back to like stats, their respiratory rate, all those kind of things.
Yep, I completely agree with you. Say again?
Just their vital signs, etc.
Yeah, I completely agree with you. And there's also one score that we use commonly in the hospital, which is called a sedation score. And you can request that this is included in the regular observations that your nurses are doing for your patients. Essentially, 0 is wide awake, 1 is easy to rouse and can stay awake, but they might be sleeping when you walk into the room. 2 is someone who you can rouse but can't stay awake for the conversation that you're having with them. And those are the patients, that's kind of the cutoff between 1 and 2 where I'd start to become concerned. And then 3 is someone who's difficult to rouse. So when you prescribe your PRN as needed opioids, if you say do not give if the sedation score is 2 or greater, then that's one way to slightly safety net your opioid prescribing. Lockout periods on your as needed medications, so not 5 milligrams of endone every 5 minutes, appropriate lockouts. And as you said, if you're unsure, start low and go slow. Completely agree, just titrate it up and review regularly, particularly in patients who are getting really high doses of opioids. What about back to Lois?
I'm not entirely sure, sorry. Yeah, no, I don't really think I know the answers to this question.
Okay. So the way that so if you visualize yourself sitting there getting the page, you're sitting there in the common room or whatever, what's the first thing that you would do?
Well, like ask someone else, like ask another doctor.
You'd like ask someone else, no problem. I can. All right. Why don't we ask Freya?
I'd go and see the patient.
Beautiful. And what would you do once you saw the patient?
I would do a quite targeted physical examination, check the vitals, and also just do an end of the betagram and then see if they're rousable and that sort of thing. So like the AVPU score. Something like that. Yeah.
Yeah. That's I haven't had AVPU in a long time. Yeah, great. Can you remind everyone what AVPU stands for?
I think A is alert, and then V is voice, P is pain, and U is, I can't remember.
I think U is unresponsive.
Unresponsive? Yeah, unresponsive. Yeah.
And in many ways, that correlates with your 0, 1, 2, 3 of your sedation score. So that's a really helpful tool to use. Completely agree with you. So you'd go and see the patient. Once you get there, you may or may not need to call for help. But if the patient's got respiratory depression from opioids, you may need senior help rapidly. And you need to stop the offending agent. If it's an oral medication they've already had, the ship's already sailed. But if they're on an infusion or a patient-controlled analgesia device with a button, then you can always take that away. Assessing the patient was correct. So GCS and sedation score exactly, and then vital signs. What vital sign do you think you care about the most, Freya?
Respiratory rate.
Yeah, I agree with you. So that's the most sensitive vital sign to the effects of opioid narcotization. But low SATs are quite a late sign in narcotization. So I'd be very concerned if I had a hypoxemic patient who was also narcotized, because I think that's someone who needs help quite quickly. Your pupils also get very small when you have a significant amount of opioid. This is something that people don't develop a tolerance to. So if you have patients who are on high-dose opioids regularly and have developed a tolerance in most of their other, particularly in their CNS, and they don't become narcotized by high doses of opioids, you may still see pinpoint pupils. So it's a useful sign, but it doesn't necessarily correlate with narcotization. Freya, I'm going to stick with you for just a little bit longer. What might you, if you could only give one medication to this, what if I say the respiratory rate's 4, and yet you can only have one medication, what would you like to give them?
I'm not actually sure, to be honest.
Yeah. So if I told you there was a drug that is an opioid receptor antagonist, would you want to give it?
Yes.
Yeah. So there is one, which is great, and it's called naloxone. We use this not infrequently to treat opioid narcotization. It binds very avidly to opioid receptors, and it displaces opioids, but it has no effect on the receptor once bound. So it's great for treating these patients. However, the one side effect is that the half-life of naloxone is shorter than the half-life of most opioids that we use. So if they need one dose, they're likely to require multiple doses, and the risk of resedation is always there. And in severe cases, patients might need an naloxone infusion. So the dose depends on how narcotized they are. 400 micrograms IV is quite a high dose, but a typical dose if they've arrested, and then you can titrate in lower doses depending on the severity of the respiratory depression or narcosis. And most importantly, if you get to step 4 and you're thinking about naloxone, you certainly should be calling for help, because it's a patient at significant risk of clinical deterioration.
Just a question in the chat from Alex. What's the difference between naloxone and naltrexone, or are they the same thing?
Oh, okay. So there is a difference. However, naltrexone is not something that we commonly use clinically. Naloxone you'll find far more often. I've never used naltrexone in my clinical practice. And if I'm honest with you, I would need to look through my notes to give you any more detail than that. But I believe the fact that you ask about it in relation to naloxone, I believe it is, as you're suggesting, an opioid receptor antagonist as well. I believe it's used. Is it used for withdrawal? I'm not sure. I'm sorry, but I can certainly get back to you guys about that if it's something of interest. Were there any other questions in the chat, Ruth?
I think that's it for the time being.
Okay. All right. Great job, Freya. Now, oh yes, as I said earlier, naloxone has a short half-life and it may wear off before the opioid, so the patient will require monitoring plus minus repeat doses. Okay, we're going to end this by going through a little vignette with our unfortunate fellow named Greg here. So Greg's a 50-year-old man. He fractured his ankle following a motorcycle accident. Very broad initial question, but just going off the tenets that we've discussed already in this lecture. How about Alex Kwan? How would you form a basic management plan for Greg's pain?
I'd start by characterizing his pain. So, like who, what, when, where, why, like we went through earlier, cardinal features. And then once I've established that, I guess overall, just checking his overall health and well-being too, see if there's anything else that needs to be currently managed, seeing if there's any liver or kidney impairment as well. And then sort of using the WHO ladder as a guideline for which analgesics use. And importantly, seeing if that's going to help him overall with his, I guess, function or ADLs or whatever's most important to him.
Excellent. Okay. Such very good summary of my lecture so far. I'm not even going to summarize it at the end for you guys. Yeah, that's great. And if you see him and his leg's not fixed yet, obviously he's going to need some invasive management of his ankle. And that's going to be an analgesic procedure in and of itself. But there'll still be post-operative pain that needs to be managed. Great. So you've instituted a basic analgesic plan. Let's say he's on some regular paracetamol. He's on some regular non-steroidal because his kidneys are fine. He's not too old. You've also got him on some as needed. Actually, no, and you've got him on a morphine patient-controlled analgesia. Actually, no, sorry, I take it back. You've got him on as needed oxycodone tablets before leading up to his surgery. If he's made nil by mouth prior to surgery, are there any changes you'd make, Alex?
Then he'd be on IV analgesia instead of PO. Yeah.
So you could use anything that doesn't need to be swallowed. Most anaesthetists would argue that there's no problem whatsoever with giving tablets when you're nil by mouth prior to surgery. I probably fall into that camp. But if people are really keen to not put anything into the gullet at all, then you can switch them to intravenous analgesics or things like sublingual wafers that dissolve with drugs like buprenorphine, which we won't get into now. But it sounds like something like potentially a patient-controlled analgesia with a button would be useful for this patient, and he can deliver as much IV analgesic as he would like. So let's say we start him on a morphine PCA before his procedure. And then he develops, checking his bloods every day, you notice he develops some renal impairment. Who haven't I asked in a while? Chris, are you there?
Yep, I am. Sorry, I was eating some dinner just now.
That's quite all right. No problem at all. Multitasking is good. What would you do? So your patient's on a morphine PCA and they develop renal impairment.
So I'd probably swap his morphine out for another opioid because of, I think you mentioned just now that the morphine gets broken down into like the morphine 6-glucuronide, which is can accumulate in renal impairment. So I might want to consider switching to maybe something like fentanyl instead.
Beautiful. Love it. All right. Okay. He's now in his post-operative journey. He's a few days down the track. You've gotten him off his fentanyl PCA, and you've switched him back to orals. So he's on as-needed oral oxycodone. And then he develops an oxycodone allergy. Why don't you have one more crack, Chris? What would you do in this situation?
I reckon you'd probably want to switch him out. I don't know if he's allergic to oxycodone. That doesn't necessarily mean that he's allergic to other opioids. Yes, so I might want to try another opioid if possible.
Absolutely. Yep. Perfect. And that's a really good point that you make, is that allergies or intolerances between opioids are very, the cross-reactivity is very low. So it's unlikely that someone's going to have a reaction to fentanyl, who has one to oxycodone, who has one to morphine. So that's good. So usually you can switch someone away depending on their intolerance to a different drug and not experience whatever adverse effect or allergy they were experiencing from that drug. So that's good. So what are some of your options? What might you consider as an oral opioid option instead?
Tramadol?
Tramadol is not a bad option at all. On that WHO analgesic ladder, it's called a weak opioid.
Okay.
It's still quite an effective analgesic, and it's a completely reasonable choice to consider switching to from oxycodone. Is there anything in particular that you'd want to check for before switching to tramadol?
Sorry, I'm not sure.
That's all right. It's a roundabout question. We'll get to it in a moment. Okay. And then long. Greg tells you he hasn't opened his bowels in 3 days. What are you going to do?
I'll probably consider some laxatives options. I mean, you have to assess the severity risk constipations to see whether or not it has some sort of like fecal impact or anything like that. Mm-hmm. But I think standard practice to start off on oral opioids is to tend to give Coloxal and Senna at the same time, because constipation is a pretty common problem.
Yes, absolutely. You're completely right. So this, it would, whenever you're prescribing opioids, it's ideal to prescribe Aperients at the same time, even if you're just prescribing them as a PRN, because the last thing you want is the nurse not be able to get in contact with you and have a constipated patient that they don't have an option of any medications to give them. So yeah, it's a great point. It says here that it looks like you're an MD2 at Uni Melbourne, so you might not know the answer to this question just yet, but do you know of any opioid preparations which are designed to reduce the incidence of constipation?
I think you mentioned Targen before, so an oxycodone / is it naloxone?
Yeah, that's right. That's exactly right. Yeah. So the theory behind it is that whilst those drugs work in opposite ways, so one's an agonist, one's an antagonist at the same receptor, naloxone has a very, very high hepatic extraction ratio. So its first-pass metabolism is incredibly high. So even though they both get absorbed from the gut, most of the naloxone is completely gone before that blood reaches the systemic circulation. So you get oxycodone systemically, but you get some naloxone in your gut where those mu opioid receptors are that are causing the constipation. And so it's combating the oxycodone effect at where it really needs to prevent constipation. It is not a very significant difference, and there's probably a lot of nice little marketing that went into this tablet and the way that it should work. But nonetheless, a very common preparation and very safe, and not a bad idea if your patient is experiencing problems with their bowels. Okay. Greg is now nauseated from his opioid. Long, I'll give you one more shot. What would you do if a patient who's developed nausea because of your opioids?
I could consider a few of the antiemetics, or we can look at metoclopramide or ondansetron, which is a bit more effective.
Yes, beautiful. Ondansetron is probably the most easiest to access, the most cheapest and most effective one that you'll get your hands on. As an aside, metoclopramide probably isn't effective for nausea below a dose of 30 milligrams, and usually we only give 10 milligrams in the ward. So probably we're not doing a great deal. But that's why I said earlier, there's a lot of other options apart from ondansetron and metoclopramide that you can use. But yeah, ondansetron is a great starting point. Completely agree. Cool. Now, Greg's been in hospital so long, had all these problems, he starts to report low mood. He's reviewed by your clinical psychology team, and they recommend commencing venlafaxine, which is an someone got to tell me if it's an SSRI or an SNRI. It's a serotonergic drug. Stuart, any concerns about starting this medication in this fellow?
Yeah, some concerns about interactions with the opioids you might be on.
Yeah. Which ones in particular?
Tramadol is one probably the most, but I guess all of them.
Yes. So mostly the tramadol, and why the tramadol?
Not sure. Same receptors?
Yeah. So it's so tramadol works at serotonergic receptors, or it works to increase serotonin release and prevent serotonin reuptake into the synapse, from the synapse. So then when you combine that with a SSRI or an SNRI, you can get a significant amount of serotonin floating around, and you're at risk of things like serotonin syndrome. So we're always cautious prescribing tramadol with any serotonergic agents. So that includes SSRIs, SNRIs, tricyclic antidepressants, and monoamine oxidase inhibitors. Though the last two are much more uncommonly used these days. It's at low dose, it's likely safe, but I wouldn't do it as a junior doctor. I would avoid combining those two medications and err on the side of a different opioid. So if you really want to start the venlafaxine, what might you consider using instead of tramadol?
As another of the weaker opioids?
You could use a weak or a strong opioid, yeah.
Assuming this same guy, so not the morphine, maybe the Plexia? I don't think.
Yeah. So tapentadol, yeah, that's a good option. It has almost insignificant serotonin effects. He's got an oxycodone allergy, he's got renal impairment, so we're kind of getting pushed into a corner a little bit here. But yeah, tapentadol would be a reasonable option in this fellow. And then finally, your core trigger, Greg, for a low respiratory rate. And I think we've already discussed in detail what you do following that, essentially assessing him for narcotization, calling for help if need be, stopping the opioid, and asking for naloxone if he looks significantly sedated or the respiratory rate is significantly low. All right. That's pretty much 1 hour, very, very quickly. So the acute pain service is a team that you'll come across constantly, pretty much while you're a junior doctor. They're always happy to be referred to and can give phone advice or come and see patients on the ward for you. These are some examples where you might consider referring. So patients with severe pain, you've worked through the WHO analgesic ladder and you're not winning. Patients who are likely to have severe pain, which might affect those basic functions that we spoke about earlier. So your ability to eat, sleep, move around, deep breathe and cough. And that's one of the reasons why I've listed rib fractures here, because they can really impact your breathing. And then patients who need intravenous analgesics. And there's multiple reasons why that might be, and I've listed some of them here. So nil by mouth, ileus, or patients who've had operations on their face or mouth, which is preventing them from swallowing tablets. What can they do? So intravenous analgesia, as we've already discussed, including patient-controlled analgesia and infusions such as ketamine, which you won't really need to worry about managing those things yourself. You can just speak to the acute pain service and they will manage them, but you need to be able to manage the side effects, particularly narcotization, and respond appropriately. And then regional anesthesia. So we can do things like fasciileaca blocks for hip fractures, commonly being done in ED these days, and infusions like erector spinae blocks for rib fractures. That's about it. It's been a bit of a whirlwind. Thank you very much for your patience. I'm glad we were able to get through all of that in an hour. I'll give some time for questions now. And if you'd all like to scan this QR code, it would just take you to a little feedback thing. All right. How are we for questions, Ruth?
Nothing in the chat. I don't know if anyone wants to turn their mic on and ask any questions. But yeah, really appreciate if everyone could scan the QR code and give the feedback so we can know how to make these sessions better in the future. If you probably most people on their phones, I might not be able to scan, but I'll put the link in the Facebook event as well, and then people can give feedback that way as well.
All right. Thank you very much, everyone, for being so active in the comments. So naltrexone is for alcohol dependence. So yeah, for withdrawal and to reduce cravings. Excellent. Thank you very much. And then thank you very much, Long, for confirming that it's venlafaxine is an SNRI. Goodness me, funny these things that fall out of your brain. Hey. Okay. Anything else? Are there any IV opioids we should be comfortable with giving in a ward in a no patient at more dose? Yes, that's a really great question. Yes, essentially yes. So the IV opioids that I would be comfortable as a junior doctor giving on the ward, the number one first thing that I would always reach for is fentanyl. So it's a highly titratable drug with a rapid onset of action and a short half-life. So you see your effects quickly and they wear off quickly. So you don't have to live with your mistakes for too long if you've given too much or the patient doesn't like it. It's also not particularly dependent on renal or hepatic function for its metabolism. It still is metabolized and excreted via these pathways, but you're not going to have toxic or potent metabolites accumulate as you would with morphine. So it would always be my first choice. And the dose that I would use almost universally is 25 micrograms. So if it's a 90-year-old, 50-kilo female, then I might even go even lower, like 10 micrograms. But a 25 microgram dose in most people is going to have some effect within 5 minutes, and it can be up titrated from there. So you could give 25 micrograms every 5 minutes to effect. And that would replicate what we would give in a PCA, a patient-controlled analgesic. So we normally, for most people, give 20 micrograms every 5 minutes. So every time they push that button, as long as it had been 5 minutes since the previous push, they would get another 20 micrograms. And we consider that very safe and very unlikely to cause overdose. So that would be, very appropriate. If you're in a situation where you had to do that, then I would consider what your next steps are from there. So obviously you can't sit there bolusing fentanyl for the rest of the night or the rest of the day. So is this someone that needs to be referred to the acute pain service? Would be definitely on my mind as well. You could use morphine as well. However, the onset of action is much longer, so the patient's less likely to get immediate relief. And there's a risk of dose stacking. So if you are too tempted to give another dose before you've seen the full effects of your current dose, which can take sort of 15 to 30 minutes, then you may end up with quite a sedated patient who's had stacks of doses before the true clinical effect has been seen. Thank you very much for that question, Emma. Any other questions?
I've just popped a link to the feedback survey in the chat as well. I think that's easy for people to access.
Thanks, Ruth. With Lahiru's little face in the chat. Was that clear enough, Emma? Is that fentanyl essentially is my answer? Yes. I love fentanyl. Great drug. Very easy to use, very forgiving.
Awesome. Well, we might wrap up there. Thank you so much, Joel, for giving us your time this evening and going through that with us. I certainly learnt a lot as well that I'll be able to use in practice. And if everyone can listen out on the Facebook page, we're going to be trying to do these lectures like the first week of every month, potentially even a bit more frequently if we've had so much good feedback. So keep an eye on the Facebook page and there'll be many more in the future.
Thank you everyone for engaging so well. I hope none of you felt so targeted or anything. You all did a great job and I really appreciate the engagement. So well done everyone.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.